Thank you. Thank you, everyone, for staying so late. I hope this lecture will be quick and we could all wrap up and go home. So this topic, I was assigned this topic, and honestly, this topic you could, design a full conference track about. So I tried to just keep it very practical and to the point from an internist point of view. So a quick, I think, cartoon. Poor guy's been rejected in a cute way. Okay, so kidney transplantation. So currently in UAE, when I came back from the States, UAE had 2 kidney transplant programs. Now, fast forward, we have 7 kidney transplant programs. And as the number of kidney transplant patients increasing in the country, I think it's imperative that internists should know a little bit about how to manage, post-kidney transplant patient, maybe diabetes, hypertension, because you're going to see more of these patients now in your wards and in the clinics. And the reason, I'm preaching here to the choir, the reason we transplant patients is basically it's the most effective treatment for end-stage renal disease, and the reason why is improved survival, and it's cheaper than dialysis, and finally, from a public health point of view, it's less costlier than dialysis, and that's the reasons. And if we look at numbers, how kidney transplant improves dialysis, this is a seminal work by Wolf, published in New England Medical Journal in 1999, which shows that after 106 days, that's close to 3 months of transplant, patients' mortality becomes, the relative risk of mortality is much lower than dialysis. So if your transplant patient survives the first 3 months, this is basically the very operative risk, then their survival is much better than dialysis. And if we look at the graph on the left side, the purple is on a transplant patient, the green or the olive green is dialysis, then the general population. And as you see in all the age groups, even up to 80, the survival of transplant patient is significantly better than dialysis. And actually, if you look into the granular data, transplant patient gain around 12 to 15 years of life expectancy than dialysis, which tells me, that question I always ask people, if there is a pill and you're going to take a pill and it's going to make you live 15 years more, would you want to take the pill? And the logical answer, if you like to live, is yes. And that pill is transplant, basically. So a lot of the transplant complication stem out of immunosuppression. It's what we do to the patient, and it's not as much as what the patient has. Their comorbidities play a role, but what we do to the patient is which kind of induces many of these problems. And what we do, just for your knowledge, we do 2 things. We do what we call induction phase, so where the patient perioperatively in the first few days gets specific agents. Either they get the ATG or thymoglobulin, which is a depleting agent, depletes all their T lymphocytes, or we use maybe gentler agents, basiliximab. Then you have the maintenance phase, where we use CNIs, tacrolimus, cyclosporin, and mycophenolate and steroids. And this is kind of this triple regimen, which is CNI, mycophenolate, and prednisone is kind of the standard cocktail right now for kidney transplant patient. I would say 90% of patients are on this cocktail, and the rest 10% might be using other things like everolimus, and very few patients with belatacept. So you're going to see these patients on the wards in your clinics with these medications, and you need to know a little bit about it. And so back to pathophysiology, this is very important because many things happen to these patients as a result of how these medications are metabolized. This is the only slide I have with physiology, so bear with me. So tacrolimus is absorbed through the gut. You have enterocyte. You have a protein in the enterocyte called P-glycoprotein, and this causes basically the efflux of tacrolimus back to the gut. So a lot of it is re-excreted back into the gut. Some of it goes through portal circulation to the liver, and CYP3A14, which is basically one of the enzymes for metabolism, will break tacrolimus, and only, I would say, only around 3 to 4% causes the clinical impact. And why this is important, so this is, I would say, a typical medications for a transplant patients. And if you look, there's all kind of interactions happening here. And if you, as an internist, find a patient walking into your ER or clinic with all these medications, and you don't understand some of these interactions, and you start playing with these medication, you might actually end up causing patients to lose his graft. And I'll give you some examples. So these interactions are very complex, and it's very important you understand what's going on. So as I said, tacrolimus, which is the cornerstone immunosuppressive agent for transplant patients, there are CNI inhibitors, so CYP3A4 inhibitors, and basically these inhibitors will make the tacrolimus level very high in the blood. And if the patient is on any of these medications, the common culprit is, of course, the antifungals, the azoles, fluconazole, voriconazole, itraconazole, and the calcium channel blockers, usually the deltazim, the verapamil. And the issue is when you put the patient on these medications with TAC, the level becomes up, and somebody then adjusts the TAC level, and some days somebody stops these medication, then the level drops so significantly down that the patient rejects. And these are the inducers, so these medications will make the level go up. So you don't need to memorize these things. So what I tend to tell myself and the physicians, whenever you're starting a new medication or transplant patient or stopping it, just go to micromedics, looks with the interaction of this medication with immunosuppression and what your change, how it's going to impact. By doing this, you at least know that what's going to happen and how you could avoid it. So this is the only case maybe I thought I'll throw in case to keep people awake and show of hand if you know what's the answer. And this is a real case. So this was a 17-year-old Pakistani girl, transplanted as a pediatric. I inherited the patient at age of 16. So in SKMC, we move patients to adult at 16. And she presented then to an ER, not our ER, some other hospital ER with fevers, hypotension, setting of acute graft pyelonephritis. And her medication at that time was tacrolimus, MMF, prednisone, diltiazem. And patient was admitted to the hospital, received, rightly so, Piptaz for her septic shock. Diltiazem was stopped because of her hypotension. And when she was discharged, the team felt that, because she had an infection, we'll cut down her MMF to a half dose. We'll send her home without diltiazem because she was still with soft blood pressure. Then she presented to our clinic. So her baseline creatinine was 100. She came back to my clinic after 2 months with a creatinine of 800. She lost the graft. So, and this is a real story. So, show of hand, what do you think? What happened? This is a 17-year-old girl, busy, maybe TikToking. I'm not going to take my medication. So, poor medication adherence in a younger patient. Or maybe because, the internal medicine team thought we'll cut down immunosuppression, so she's going to reject. So, who'll pick A first? So, show of hand, anybody would like to pick A? So I don't see, okay, so one physician for A, I like it. B, so the internal medicine department decided to cut MMF because she's infected. Okay, so 3 people. Diltiazem was stopped at discharge because of hypotension. Anybody? Augmentin was introduced as discharge. This caused something, 1, and bad luck. Anybody? So I see many people didn't have, so actually diltiazem. So diltiazem is an inhibitor of CYP3A, and when you inhibit CYP3A, TAC level is very high, and it's therapeutic. But when you stop it, it becomes subtherapeutic, and you reject. So a simple change, somebody did the right thing without checking. You made the patients go back at age 17 to dialysis after 3 years. The average lifespan of kidney transplant is 15 years. Now she's highly sensitized. Transplanting a 17 years after her first kidney transplant is very difficult. So a simple medication change might change patient's life forever. So the message is, if you're not sure, either ask or check. So, yeah. Second things, common mistakes happen on the floor. Patients interchange. So tacrolimus comes in 2 formulations, short-acting, which is BID, and there's long-acting, once daily, so Prograf and Advagraf. And all the time in SKMC, I find my patients who are taking once daily, somebody prescribed in the system as an inpatient BID. So they are taking 4 milligram once daily, and I find somebody write them for 4 BID, or the other way around. And this, of course, will mess your whole TAC trough. Same thing for mycophenolate. Patients are using MMF, which comes in 250, 500, 750, and 1,000, and or mycophenolic acid. They come in 180, 360, 540, and 720, and this always interchange and causes some problem. So immunosuppression troughs, they all should be checked in the morning. People will say, no, my patient takes it at 1 p.m., so I'll check it at 1 p.m. Unfortunately, that's not accurate because the body, the way it metabolizes these medications, it changes from the morning to evening. So all the troughs for tacrolimus, CNI, cyclosporin, sirolimus should be checked in the morning. And unfortunately, I see this practice, at least by the nurses. They check the TAC trough, and like vancomycin, they wait for the result to dose it, which is wrong. So you check the trough, you give the medication, and once the result is out, then you could adjust the next dose. And if you find the trough, again, in internal medicine, I have residents call me, patient's trough is 30. Ask the nurse, maybe they checked it after they gave the medication. The commonest mistake, right? Once you give the medication, the trough is wrong. So make sure the medication was not given and the trough was done correctly. So these are the target. Of course, you don't need to set the targets, but I get these calls all the time. What is your target? So in the first 3 months of my, transplant, the troughs are 8 to 12. From 3 to 12 months are 6 to 10. Then 1 year, actually, we don't do any more 4. So they are mainly, I would say, 5 to 8. And cyclosporin, patients who are done, I would say, in the early 90s, still on cyclosporin, those are the troughs. So you don't need to know them, just for your knowledge. So now we'll talk a little bit about complications. So actually, cardiac death is still the commonest reason for death in transplant patient, and the commonest reason for loss of graft, because most patients die with working graft because of cardiovascular reasons, and it's 35%. So it's very important that you have regular cardiovascular screening, you optimize their diabetes, blood pressure, and lipids control, and use all the good things we've been talking about, ACE inhibitors, SGLT2s, statins, and under the guidance of nephrologists. So again, one thing I always see patients start on statin by I think cardiologists or internists, and they don't know there's actually interaction between tacrolimus and cyclosporin statin, and putting a transplant patient a full dose of statin actually might cause rhabdomyolysis, might cause hepatotoxicity. So there is adjustment of doses. So there are interactions, and you need to be aware. So this is kind of a quick reference table for the interactions, and you see, like pivetastatin is contraindicated. We don't use it commonly, but it's not. So the safe medication is pravastatin and fluvastatin. Simvastatin is contraindicated, cyclosporin, but it has to be reduced with TAC. So you need to know these interactions, because if you don't, patients will come with muscle ache, will come feeling tired, and sometimes they come with rhabdo. And I've seen a couple of cases, especially in elderly patients. Hypertension, of course, these are end-stage renal disease patients. Most of them have hypertension prior to transplant, but post-transplant, there's different reasons for hypertension in the immediate, early, and late. In the immediate, of course, these patients, we load them with fluid around transplant, so there is hypervolemia, the medication, the induction. Then sometimes we stop the antihypertensive prior to the surgery, so they have a rebound hypertension, then the pain control. And as they move forward, the reasons change, but there is specific ways to manage this hypertension. The targets, usually it's, I would say, 130 to 80. In the first few months, we try to keep it higher, then we slowly bring it down. Most transplant patients, we prefer dihydropyridine, so either amlodipine, nifedipine. We avoid, of course, as I mentioned, diltiazem and viramipil for the interactions. RAS inhibitors, I always get the question, can we use ACE and ARB? Yes, we can, but we don't use them in the first 6 months, and the reason is, naturally, the creatinine will go up with ACE and ARB. Then you start, scratching your head. Is this a rejection or this is a RAS effect? So in the first 6 months, we don't use it. We use them later. And beta blocker. So usually, I think amlodipine for patients who have mild hypertension, nifedipine, you have more leeway with the dosage, 30 once daily or 30 BID, 60 BID. So these are the medication we use. You could use other agents also, as far as you know what is the interactions. Then PTL, post-transplant diabetes, it's an entity of having diabetes once you get transplanted after usually 45 days of transplant, so it should be diagnosed after like 1.5 months, and this happens almost in 30% of the patients. So it's very common condition. So as you see here in the graph, patient get pre-transplant, it's not diabetic, then once you get transplanted, and then they become diabetic. And you see the incidence depends on the study from 15 to 30%. In our patient population in Sheikh Khalifa Medical City is around 35%. And that what are the risk factors? This is, being elderly, male recipient, the usual risk factors. I think the less common risk factors, patients with hep C and hypomagnesemia seems to have more, plus patients who are still on steroids. Some transplant patients are also on steroid sparing, so those will have it less, but basically these are the risk factors. And this is kind of the usual. You have to do pre-transplant counseling, weight control, life modification, and after the transplant, you have to follow it closely. So how do you manage these patients? Again, because the GFR is very unstable in the first 6 months. As the GFR is improving, we avoid oral hypoglycemics in the first 6 months. We tend to use insulin. After 6 months, we use oral hypoglycemics. The question I always get is about using SGLT2s in these patients. Yes, you could use them given that they don't have UTI, because UTI is very common, as we'll see in kidney transplant patients. Infectious complications, what we're talking about, very prevalent, given that these patients are immunosuppressed. We have a couple of ID experts here, so I'm not going to preach to them, but UTI and cytomegalovirus, I think these are the commonest two things we deal with in SKMC. And these are the 3 phases of transplant: early, which is usually the infections are related to operative complications. Then after usually 3 months, you start seeing CMV, UTIs, BK, and other infection, and then on long run, you see the same same infections. Is there a point of treating asymptomatic bacteriuria in transplant? Because that's also a question I get from internal medicine. We check cultures, patient asymptomatic. Studies shown in the early and the late phase, and it seems there's no benefit. So this is one of the studies which is looked at in Mexico. If you could treat patients in the first 2 months, it seems there's no benefit. And this study after the 2 months, the same thing. And basically, there's no benefit of treating asymptomatic bacteriuria, which is very common in transplant patients. I would say 40% of all transplant patients have asymptomatic bacteriuria, so you shouldn't treat it. ESBL, pretty common in our patient population in SKMC with transplant. I would say around 30%. This study says around 50, but I think in our patient population it's very common. And the reason I'm saying so, because a lot of these patients get admitted with early sepsis to the ER. Internal medicine resident might come and put them on Piptaz, and Piptaz doesn't cover ESBL. And every now and then we have patients who decompensate and end up in the ICU because we didn't start with the right antibiotic. So my advice to all the residents or the internists, if you have a previous culture which is with a very clear antibiotic and resistance pattern, then you should use that antibiotic. If you don't, then you should assume the worst, start with meropenem, then de-escalate as you have better cultures. So currently, these are the guidelines. Again, these guidelines are international guidelines. I don't think they align with current patterns we have in SKMC. The guideline says you start with Piptaz, except if the patient is critically ill, then start with meropenem, and if there's a risk of ESBL, then consider meropenem. Other things, if the patient has a stent, remove it. If the patient has a Foley, remove it or exchange it. And patients with recurrent UTI, we always refer them to urology to get a full workup and find what is the reason. Plus, getting the diabetes in control. If they have constipation, treat the constipation. So I have 1 minute and have maybe 4 slides. CMV, we could have a conference about CMV in transplant, so I'll have few slides. CMV is very common due to cell-mediated immunity suppression. The way to, there's CMV infection or viremia where you detect CMV in blood. You have CMV syndrome, so you have CMV in blood plus symptoms, patients feeling tired, feeling weak, maybe leukopenia. Then tissue-invasive disease based on the presentation. Pneumonitis, the common we see in our patient population is colitis or gastroenteritis or esophagitis. Rarely you see, in transplant, I've never seen retinitis. You see it in HIV patients, but it's very common. And the way to diagnose it, of course, you do CMV PCR, so you look for the DNA in the blood, plus you need to do tissue biopsy. If patient has a negative PCR, that doesn't rule out CMV. You might have colitis or pneumonitis without blood CMV. And the treatment, the first agent is valganciclovir. Patients who are clinically unstable or have GI disease, we use IV ganciclovir, and it's renally toxic, so you should dose it correctly. Second lines, I haven't used second line in the last 8 years, so it's extremely rarely used. Okay, and finally, cancer is very common. It's 4 times more in general population, and the reason is immunosuppression, plus all the cancers related to viruses like PTLD and Kaposi sarcoma is higher. So this is basically the relative risk in transplantation. As you see, Kaposi is very high. Skin cancer, PTLD, non-Hodgkin lymphoma, they're all common. And it's very important for all transplant patients, they should get age-appropriate screening, get every 2 years, skin surveillance looking for skin cancer. Immunosuppression should be adjusted by the transplant team if there is cancer. So it should be done in close collaboration. So 6 seconds. And quick, so this is a slide about my program. We're the largest transplant program in the country. We've done 600 and we're growing. And this is my team. So it takes a small village to run a transplant program. So conclusion, so kidney transplant patients have a lot of complications, cardiovascular, metabolic, infectious, and oncologic, and they should be managed properly. And this should be all done in a multidisciplinary team fashion, could not be done by one person. So if you have any concerns, questions, feel free to ask, or we're more than welcome to refer patients to us. Thank you.